much on ECD and lungs. However, lungs are affected in this disease. We all know what's the problem, and I don't know if I can point with the mouse, probably not. But we know that histiocytes are the problem. And histiocytes, in general, are good cells. However, in this disease, because there are so many, what they do, they infiltrate some organs, including the lungs. This will lead to some scar tissue, and the scar tissue will make it hard for the oxygen to get from the air into the lungs, which can make it harder to breathe. Now, how many patients have lung involvement? 1/4 to 1/2 of the patient will have pulmonary involvement. It can involve both the pleura, which is the lining of the lung, or the parenchyma, which is the lung itself. So here in this picture, in yellow, we can see that that's the pleura, or the lining of the lung. And the lungs, the way I imagine them, is like 2 bags filled with air, or balloons filled with air. Now, outside, we have 2 linings in which everybody has a little bit of fluid. It's normal. We have around 10 to 15 cc's. Now, in ECD, we can develop pleural effusion or fluid in between those 2 linings. Now, imagine that the lung is filled with air and the lining is filled with water. The weight of the water is much higher than the weight of the air, so the lung will just collapse. And that will lead to shortness of breath. And in general, we have to drain that fluid. Now, the fluid can come in there from the disease itself, or if there is any cardiac involvement, the cardiac failure can also lead to fluid around the lungs. Now, when the ECD affects the lung itself, the balloon just becomes stiff, so there is less air getting inside that balloon or the lung. So what are the symptoms when the lungs are affected? We have cough, shortness of breath, fatigue, also chest pain at times. What testing do we need? So in general, when I see a patient that I would suspect the disease, I would always start with a pulmonary function test or a breathing test, followed by a 6-minute test, some imaging, and then, depending on the case, bronchoscopy with what we call liquid biopsies, and I'll show you what's that, or bronchoscopy with biopsies. So the breathing test takes around probably an hour and a half to complete, and includes spirometry, lung volumes, and diffusing capacity. The spirometry part involves breathing in as deep as you can and breathing out as fast as you can into a tube. And you can see the graph on the left. It's pretty much the way a graph should look, but the one on the right, somebody didn't really do a good job. So the test involves a little bit of effort. Now, if you're really, really short of breath, it's actually going to be difficult to perform. Lung volumes, so this test measures how much air is in your lung. And as I mentioned earlier, in ECD, there is decreased amount of air because the lungs become stiffer because of the scar tissue, and this is called restriction. But the test involves sitting in a large glass box. It looks like a phone booth. And while you are in this box, you will breathe in and out through a tube. So this is pretty much how it looks. And again, you breathe in and out through a tube, and we get some numbers and tell you what those numbers mean. Now, diffusing capacity measures how well the oxygen gets from your lungs into the blood. And it involves breathing in a certain gas and then breathing it out. Again, we get the number and we tell you if it's decreased or not. If there is a lot of scarring, we do expect that this number will go down. Now, the 6-minute walk test, you just do what it says. You just walk for 6 minutes. You walk with a monitor on your finger that monitors your oxygen, and we tell you if that oxygen dropped or not. In general, healthy subjects can typically walk 400 to 700 meters. Now imagine if you're short of breath, you will walk less than that. But the test is mostly done to see how much your oxygen drops, because based on that number, we may or may not prescribe oxygen. Now, in terms of imaging, of course, we start with the chest X-ray, and many times we go to a CT. On the X-ray, the lung damage often shows up in a characteristic pattern. However, in many times, chest X-ray is normal. Now, I just put this here because I want to show you some images and just so you know what we are looking at. So this is pretty much almost like looking like the old photography, black and white, developing films. I don't know if you're familiar with that. But in general, the air on the X-ray, even on a CAT scan, is black. The fat is gray, and everything that's denser, like bone or soft tissue, even tumors, they're going to look whiter. But for example, the heart, which is very dense, is going to look white as well. And of course, if you have any metal in your body, it's going to look very white. So here on the right side, we have a normal X-ray, and we see white in the middle, which is the heart. We see, I don't know, I don't have a, I think somebody had a pointer earlier. No? But anyway, I think you can see, I mean, we see white, the collarbones, and everything that's black is normal lungs. Now on that X-ray on the left side, and it's a shot from the front, is normal, but the right side is all white. So that's all fluid in the lungs, or in that pleural space, or the lining of the lung. Here, same example, we have the normal X-ray, and on the other X-ray, we see the lung is abnormal, and we see all that white, it almost looks like some holes in that white. That's very abnormal. So definitely, if I would see that X-ray, I would definitely send you for a CAT scan. Now the scanner, the CAT scanner, uses a computer to combine X-ray images taken from many different angles. The way I imagine it is almost like I would lie down on a table and I look at myself slice by slice by slice like salami or a loaf of bread, depends what you like more. So the slices are very, very thin, so you can see a lot of details, many things that you could not possibly see on an X-ray. So these are just some examples of patients with ECD, and here we have arrows that are pointing. So the lower one, there are many small white dots. Those are pulmonary nodules, and you can see on the B, figure B, the white arrow is pointing to some white lines. Those lines are not normal. We call that thickening of the interlobular septa, and that's very typical of any interstitial disease, really. But in somebody with ECD, sorry, definitely it's very, very suspicious for the disease itself. Now the bronchoscopy, like I always tell the patient, it's not a big deal. I did it on myself with no sedation. It's a very, very small tube, and pretty much it's passed through the nose or through the mouth. Now, on everybody else, I would do it with sedation, so don't. So, and what we can do two things. We can do what we call liquid biopsies, in which we squirt saline and we pull it back out and send it to the lab, or we can do biopsies. But the biopsies through the bronchoscope are actually very, very small. They are no larger than the head of a pin. So when we do the biopsies, there is a risk of bleeding, and of course there is a risk of lung collapse, but it's very, very low. I would say that probably the risk of bleeding is 1 in 1,000, and the risk of lung collapse, I would say it's 1 in 500. But the most common side effects are temporary sore throat and hoarseness, and majority of patients do cough immediately after the procedure. So this is the bronchoscopy, and in that figure over there, that's the liquid biopsy that I told you about. And down under the microscope, we can see the double contoured histiocytes in that BAL or liquid biopsy in a patient with ECD. Now the diagnosis. So we consider it highly probable when we have the presence of radiological hallmarks of interstitial lung disease and the detection of these stains in the BAL. So most of the time, to be honest with you, a biopsy of the lung is not needed, especially if there is a biopsy that already proved the disease. But we still would probably do the bronchoscopy because there are many, many infectious diseases that can mimic interstitial lung disease, especially if you've been on steroids for a long time, and also side effects of medications. So we would do the bronchoscopy, but probably no biopsy, just bronchoalveolar lavage or the liquid biopsies. So the treatment, not everybody requires treatment, and treatment is really not, the pulmonary involvement is really not the main indication for treatment. Whatever works for your systemic disease is going to work for your pulmonary disease. However, if you have symptoms due to pleural effusion, which is the fluid around the lung, if you have low oxygen, if you have cough, you will need symptomatic treatment. So for the pleural effusion, we do a procedure to drain this fluid, and the procedure is called thoracentesis. It's a one-day procedure. It's done using an ultrasound. So you come in, we look with the ultrasound, we find the fluid, we use a very small needle to numb the skin, and another very small needle to drain the fluid. The procedure should not be very painful except for that needle stick that's given for the local anesthetic. So it should not hurt more than an IV line, in my mind, even though I never had it. So this is how the fluid can look. The color doesn't really matter, and we cannot really tell much based on the color. So every time we drain the fluid, we will have to analyze it. For the low oxygen, of course, we prescribe oxygen, and we usually prescribe it at the level of 88 or 89 plus some other criteria if you have them. But the oxygen therapy, you have to understand, it will not stop the lung damage, but it will make you breathe easier. It will prevent or lessen complication from low blood pressure or blood oxygen levels, will reduce blood pressure in the right side of the heart, because if the oxygen is low, your lungs become, the vessels in your lungs become so stiff that the heart is going to pump towards stiffer vessels, so the pressure can go up. And that's why we give oxygen for that pressure to go down. It also improves your sleep and sense of well-being. And depending on when you are hypoxemic or when your oxygen is low, we may prescribe oxygen while you sleep or while you exercise or continuous. Now, in terms of cough, there are many cough suppressants over the counter, and to be honest, I don't think I prefer one or another. These are the ones that are most commonly used. When it comes to the prescription drugs for chronic cough, I in general prefer codeine-based cough syrup. That seems to work the best. And in terms of prognosis, so the researchers concluded that pulmonary involvement can add to the morbidity, but has limited impact on the overall prognosis of the disease. But what's very important with any disease, and including pulmonary disease, eat well. I don't know if this is very healthy, but it looks good. Remain very active, and absolutely no smoking. Thank you. Any questions?
With my ECD, I do have involvement in my lungs, but I was also told that I have a paralyzed right diaphragm. Do you see that?
Well, you know, I don't know if that's me or you. The paralyzed diaphragm can happen, you know, I'm not sure. It's probably infiltrating the diaphragm nerve, you know, in the tract. I'm not sure if you have, do you have any involvement of the mediastinum, or it's just the lungs? Just the lungs. Well, I'm not sure if that's the cause, but probably if it wasn't there before, probably it is. If it's only one diaphragm, we tend to think that that should not affect your breathing very much. If it's two diaphragms, there needs to be a treatment, because you won't be able to sleep, because every time you would be on your back, your diaphragms will go up. Now, in terms of treatment, there is surgery, which is the more invasive, in which pretty much the diaphragm is pushed down and there is a cover placed on it so it doesn't come up. Pacing of the diaphragm so it contracts better, but the most non-invasive mode of treatment would be a CPAP or a BiPAP machine. I'm not sure if you're familiar with that. So that would be the best for you probably. Yeah.
Because they told me that the diaphragm works until I exert any type of exercise, and then it stops.
So, you know, I'm not sure if that's truly correct. With each breath, we use our diaphragm. It's just that with one diaphragm down, you should be able to compensate with the other diaphragm. It's mostly when you sleep, it's actually mostly when you should have more symptoms.
Yeah, I don't have a lot of problems with it. I get along okay. It's
That's
just
great.
I get winded, you know, at times, and I sometimes have to stop.
Yeah.
So, okay,
Yeah.
thank you.
You're welcome.
I have a question. My daughter has cysts in her lungs, and she was kind of told that she shouldn't ever fly. Is that true?
Well, I mean, I'm not looking at her CAT scan, but no, that's not true.
Okay.
There is always a risk of flying when you have, you know, cystic lung disease because of the barometric pressure change. However, we even looked at collapsed lung from procedures. Many times the lung collapses from procedure, and MD Anderson actually, we looked at safety of flying if you already have a lung collapse. And it's actually quite safe. You know, there is, probably, you know, there is not enough data there to say, yes, you know, you can fly, but I don't think I ever told a patient who has cysts not to fly, especially if they want to fly to see us. And, you know, I mean, there is no way, I mean, to function in this world if you can't fly. Did she ever have a collapsed lung or?
No.
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 I
Now,
think
she does get chest pains. Could that be something?
It can be if the cysts, you know, I don't know if they're big or not, or, you know, but I think in general, any disease in the chest can give you some chest pain. Yeah. Yeah.
I've been told that I don't have lung involvement with ECD. However, I do have asthma and have for years. I was wondering, would having asthma predispose me?
I don't think so.
No? Okay.
No, I don't think so. It's completely different pathology. Yeah. Yeah. Any other?
Well, if there aren't any other questions, we're going to take a break now. So we'll give you about 10, 15 minutes. And please come back in afterwards, and we'll continue with presentations. Thank you very much, Dr. Grosu.